Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hi, I'm Dr. Eileen Scully from Johns Hopkins University School of Medicine, and welcome to episode 3 of Clinical Clips from CROI 2025. So I'd like to start with a few presentations about cardiovascular disease in people living with HIV that were exciting from the conference today. So the first I'll talk about is abstract 176. This was a cardiovascular analysis from the START study. In this analysis of that previously reported study, they sought to address the question of whether the documented increase in cardiovascular disease risk associated with HIV is present in this ART-naive individuals with high CD4 counts, and whether initiation of ART affects this risk. So they analyzed this during the initial period when there was either treatment or no treatment, during the extension phase when ART had been recommended for all participants based on an interim analysis, and over the entire study period. Among this low-risk group, there was no difference in the cardiovascular disease event rate overall between the early and deferred arms. In a sex-stratified analysis, immediate versus delayed ART was actually associated with a reduced risk of cardiovascular disease. This effect was specifically seen in women with a hazard ratio of 0.19, but not in men, for whom the hazard ratio was 1.33. Now, the authors were very cautious in interpreting this subgroup analysis, but given the prior data concerning differences in the augmentation of risk by HIV in women, this study raises important questions about whether treatment may have a greater impact on cardiovascular disease risk, specifically in women, or in other populations at higher risk. So next, there was additional data presented from the landmark Reprieve trial. The trial was global, but in this presentation, the investigators were looking specifically at a mechanistic sub-study of the overall trial that enrolled 804 individuals in US sites only. They evaluated the relationship between a few baseline factors. These factors included non-calcified plaque, inflammation, as measured specifically here by high-sensitivity CRP and IL-6, and subclinical myocardial injury, which they measured with low-level troponins, and looked for the relationship between those baseline factors and subsequent major adverse cardiovascular events, and explored the modification effect of the statin use based on, in the context of these baseline parameters. So with that as our background, what they found was that baseline non-calcified plaque was associated with a higher risk for MACE, with a hazard ratio of 2.5. Also, elevated high-sensitivity CRP, IL-6, and subclinical myocardial injury, as measured by the high-sensitivity troponin, were also associated with these events. In exploratory analyses of the impact of pitavastatin on major adverse cardiovascular events, those appeared higher in those with non-calcified plaque, with it trended towards a greater impact in those with elevated high-sensitivity CRP. So the pitavastatin data was exploratory because of the low rate of events, but this does suggest that there may be an enhanced effect in certain individuals with baseline risk factors, and hopefully understanding more about them through these mechanistic sub-studies will allow us to even more finely direct our interventions to prevent cardiovascular outcomes. I'll just also briefly highlight one other analysis from Reprieve. This was in poster 838. This additional analysis looks specifically at the impact of switched integrase inhibitors on the subsequent occurrence of major adverse cardiovascular events. In this analysis, they described emulating a series of target trials across periods of follow-up, and at each period they evaluated people who were on an INSTI and who switched to an INSTI-based regimen during the following period and looked at the incidence of their relevant outcomes. With this approach, the estimates significantly increased for obesity, metabolic syndrome, hypertension, and diabetes in people who switched to integrase strand transfer inhibitors, but they did not observe any increase in major adverse cardiovascular events, somewhat reassuring regarding the potential risk of this class for those outcomes. So now let's shift gears a little bit and talk about some of the studies relevant to neurologic outcomes. So there was data from abstract 169 presented by Dr. Sikor from the University of Pittsburgh. This study was a follow-up to a previously published cross-sectional analysis from the ACTG that examined HIV in the cerebrospinal fluid of individuals with HIV and found a relationship to neurocognitive function. In this follow-up study, the investigators sought to evaluate longitudinal trends. So they assessed cell pellets from about 13 cc's of CSF and assayed for HIV DNA. So all participants had detectable HIV DNA in the CSF at least one time point, and 69% of the participants had detectable DNA at least 3 time points on a median of about 4,400 cells. So importantly, there was no evidence of decline of CSF HIV DNA over time. They also looked at some markers of inflammation, including IP10, TNF, and CCL2, and neuronal injury, and also found them to be relatively stable over time. So this study overall demonstrated that there is detectable HIV DNA in the CSF and that this persists over time without evidence of decay. Open questions include determining whether or not this represents replication-competent virus and whether this has implications for either neurologic health or for efforts to eliminate the HIV reservoir in progress towards an HIV cure. Now, shifting gears a little bit to talk about potential interventions that might address cognitive issues. So earlier this week, we talked about a couple of studies on semaglutide, the GLP-1 agonist, with relationship to liver health and fatty liver. But today, we'll look at other studies looking for additional impacts. So this study presented results from a phase 2b single-center trial that enrolled adults with well-controlled HIV and an increased waist-to-hip ratio, so central adiposity, a BMI greater than or equal to 25, and who were initiated on 32 weeks of semaglutide as compared to placebo. For the 108 participants included in the trial, there were 40% female participants and a median age of 53, and they were all evaluated by a standardized FDA-approved computer-based cognitive test at baseline and at 32 weeks, which tested multiple subdomains of neurocognitive function. After adjustment for sex and CD4 count, visuospatial learning scores were significantly higher after semaglutide, even after controlling for changes in inflammation as marked by high-sensitivity CRP. Notably, they were unrelated to changes in either total or central adiposity, so further study is needed to understand the mechanism of this effect, whether it will be durable, and whether it can be generalized across different populations. So a separate study looked at the participants of this initial trial, this same trial, but for a very different outcome. This, again, looking at it for another potential off-target benefit of semaglutide. This was presented in Abstract 181. And here, using the same set of participants, although a subgroup of them who had evaluable samples, they looked at 3 different epigenetic aging clocks. So epigenetic aging is a concept based on measuring the accumulation of changes in DNA modifications that alter the overall structure of DNA and can affect gene expression. This is what we are talking about when we refer to epigenetics, so on top of the genome modifications. Epigenetic aging clocks measure some of these modifications, such as DNA methylation, across the genome, and then use algorithmic analyses to predict how these features will relate to biological age. There are several generations of aging clocks, the first of which estimates chronological age based on the DNA modifications. The second provides an estimation of mortality, and the third generation estimates a pace of aging. So in this study, they explored whether semaglutide would impact any of these measures after the 32 weeks of treatment that I've already described, and they adjusted analyses for sex, BMI, high-sensitivity CRP, and soluble CD163 at baseline as measures of inflammation. They analyzed 45 individuals in the semaglutide group and 39 controls. So at baseline, these participants, who are people living with HIV, had an estimated increase in chronological age by about 3.74 years on their first generation aging clocks. This is consistent with prior reports of the impact of HIV on aging clocks. By the second generation mortality clocks, they had an estimated increase in age over actual chronological age of about 9 years, and their aging pace was actually equivalent to the general rates at baseline. So the primary finding is that in the placebo group, age estimations increased in the second generation mortality clocks and in the third generation pace of aging clocks, whereas in the semaglutide group, both the second and third generation clocks decreased at 32 weeks. So controlling for baseline factors, semaglutide led to about a 3-year decrease in the annual rate of epigenetic aging mortality risk and about a 9% reduction in the pace of aging on their third generation clocks. Overall, this was interpreted as a stabilization of epigenetic aging, and in this group of people living with HIV who also had lipohypertrophy. So further studies are needed to investigate the long-term impacts of this type of stabilization, and one key question for both of these semaglutide studies is whether it's a direct impact of the drug itself or it reflects differences in exposures, as the treatment itself may drive different patterns of exposures, including changes in your dietary habits and potentially also behavioral factors such as smoking. So lots more research still to be done in this area. So thank you for joining us for Clinical Clip 3. Please refer to the landing page to claim your continuing education credit and for slides. And please be sure to come back for our 4th and final clinical clip from CROI 2025.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.